First of all, I am thankful to Dr. Vaishali Vasavada for giving me this opportunity. And I have these children coming to me with visually significant cataract. And we have to see each of the child very carefully. And my topic is surgical tips for surgery in small eyes. While I got this topic, initially it was some different topics, but ultimately I found that this is the topic. I have to speak on the surgery in small eyes. Then I thought that what is the small eyes? I divided it into two: small eyes of infant with normal growth. There is a group of eyes where eyes are small, young children, infant, where growth is normal. But there are other where there is a limited growth, such as those having microcornea, microphthalmos, or some of the other issues, associated conditions are there. I will show the example also. So, a small infant eyes with normal growth. There are several issues because eye is a growing eye. Whether IOL implantation should be done or not done, or what is the age, till what age we should do IOL implantation. It could be technically challenging. Of course, post-operative inflammation and glaucoma, there may be higher chances. Then whether to implant IOL or not, the general consensus in pediatric of the pediatric surgeon is to implant IOL in normally developing eyes wherever possible. Till now, our this as per literature is 7 months retrospectively, because even previously we implanted IOL in younger children than 7 months. But that is the agreed thing, that 7 months or more, I think it gives equivalent or better result. But 7 months or less, there may be number of publication, number of the post-operative complications may be higher, but maybe after 5-year results may be visual outcome remains same. So what I do selectively, when I say that selectively I implant IOL in children even less than 7 months in normally growing eyes. If child has axial length of 17 millimeter or more, and if the diameter of the cornea is 9 millimeter or more, these are the children where I will like to implant IOL. If it is 8 millimeter corneal diameter and axial length of globe is 16 or 16.5 or less, I don't implant IOL. That is one. Although it is these are some of the studies which are published in the literature, IGO and European Journal. We have published of the children in the first 2 years of life cataract surgery, and in the infant. Conclusion of those studies were meticulously performed primary IOL implantation and primary capsulorhexis and anterior vitrectomy in the first 2 years of life is safe and effective for aphakic correction. This is a small video I will like to show infant's eye. This is a 10-month-old child. I think no contraindication. Usually problem is in the child less than. So this photograph was taken, child was smiling. So this is some natural smile. And while you dilate, you have to dilate each of the eye where you want to do cataract surgery, because anatomical this is extremely important, because you may find PHPV, you may find some of the other issues, posterior lenticonus, if you do not dilate, or there may be several of the points which you will find while you will dilate the pupil. So here Here this 10-month-old child, during surgery we realized that this posterior capsule was less. Actually it was a posterior lenticonus. So you have to be, there are classical lenticonus also where we have done surgery. So here it is up to you whether you want to do primary posterior capsulotomy before or after implantation. What is most important is to secure the IOL in the capsular bag, and then doing posterior capsulotomy several times. I do it most of the time before, but here in this case I have done it afterward because I wanted that IOL should be in the capsular bag. And I have a child which I have shown this example yesterday also. In 1997 I operated this child, infantile cataract, and I have followed this child for 25 years. That point of time I did primary posterior capsulotomy and anterior vitrectomy. That was the start anywhere in the world. And this child, after 25 years, bilateral pseudophakia, 20/20 visual acuity, and grown up now doctors. He has completed MBBS. So you have to follow them. I mean to say, you don't forget once operate and forget. That is just the first step. And then this is another small video. Particularly beginner, they have to stain the anterior capsule with the trypan blue dye, but it is not must for those people who have excellent experience. A hydrodissection and removal of the cortex from the capsular bag. And then after removal of the cortex, primary posterior capsulotomy. Then is the important, what is the size, should be the size. It should not be very small. I think probably in this case it is 3 millimeter or so. Ideally it should be 3.5 millimeter or more. And then limited anterior vitrectomy and implantation of IOL into capsular bag. Most of the time I do capsular bag implantation, and some of the cases I do even posterior capture of the optic. Small eyes with the limited growth, axial length, small axial length but normal globe. These are the patients where normal growth children we may implant IOL, but axial length should be 17 or more. If there is a microcornea, corneal diameter 9 millimeter or less, or axial length is less, then we may not implant IOL. We have found several of the children with persistent fetal vasculature where there may be small cornea and microcornea. So I think these are the patients where you may not implant IOL. This is one of the child. I will show the video where axial length was less and cornea was small, where you may not implant IOL. We have published that in European Journal of Ophthalmology. This is one child which is published in Indian Journal, where even pupil was also very small, but it was left aphakic. Though favorable outcome can be achieved with IOL implantation in the bag with persistent fetal vasculature, eyes with the microphthalmia and microcornea should be left aphakic. This is one child where persistent fetal vasculature was there, but this was with microphakia. It was because ultrasound was done before, so we could detect that there is a stalk. If you do not do ultrasound, in such cases you may detect it operatively only. It was a very thick anterior capsule. Capsular bag was small. It was a just microspherophakia type of picture. And with great difficulty, rhexis could be completed. And this membrane, this was the posterior capsular membrane. Primary posterior capsulotomy was done, and adequate capsulotomy was done, anterior and posterior, and it was left aphakic without IOL implantation. Very few studies have shown the IOL implantation in these eyes, whereas never take risk and do not implant in these micro-ophthalmic eyes. These are the definitely cases where you should not implant. These are eyes where there is a microcornea and micro-ophthalmos. There will be complication in these children, whereas all these children never implant IOL in these children. And there will be complication like glaucoma, such as one of the child has only 4 millimeter and other eye 4.5 and 5 millimeter cornea. It was left aphakic. Take home message is favorable outcome can be achieved in eyes with the micro-ophthalmos and micro-ophthalmia using meticulous surgical technique. In the present era, those children where eyes are small but growing eyes, one may implant IOL. So thank you very much for giving me this opportunity. These are the children, young children who are growing up, but I have maximum follow-up of 32 years also. I have followed these children where I have implanted IOL. Thank you so much.
Thank you, sir. And before we move on to the next talk, if there are any questions, we can take 2 questions from the audience. Okay. If not, sir, I have a question for you.
Yeah.
I saw that last video where you used the Malugin ring to dilate the pupil, and this was a micro-ophthalmic eye. So for all of us, we have an option of using these ring expander devices which are more single piece and little bulkier versus the hooks. So what would your advice be, and what are the challenges in using such expander devices?
I think I use most of the time, if I have Malaysian ring, I use it in these small eyes I have used, but sometime even if it is a 360-degree posterior synechia, I may use even hooks. But I have most of the time I have used Malaysian ring in these children.
Varshini, any comments?
I think Malaysian rings are definitely a little more bulkier to put inside and take out.
Madam, any comments from me? So yeah, I think I am more on the hook side, because like sir said, one, we are more familiar sometimes, but also they help you to break synechia, and a lot of these may have mid-peripheral synechia which you can't actually see. So I think that was just one point I wanted to highlight, and in the interest of